So we're going to gather the students around the table eventually, because we're going to look at some concentrated areas to press on. This is about pressing. This isn't about pulling. Concentrated areas to press on that are kind of hard to get to, but are often involved in the low back first and then the neck and shoulder. So once you know where they are, then it makes sense on why we do the positioning the way we do. Okay. This is psoas. What's on top of it? Skin, superficial fascia with fat in it, deep fascia, omentum, guts. Okay, so it's hard to get to. This is Quadratus lumborum. It's got stuff on top of it too. So it's hard to get to. And so we're going to use positioning to try to give us an advantage in how we're going to get to stuff. Same thing with the scalenes up here. It's not that they're covered with a lot of stuff, but there's all kinds of vessels and nerves coming out through there. So the whole brachial plexus, you've got your arteries, you know, and so pressure on those areas is going to be uncomfortable. And it also, you know, if somebody's got a vulnerable artery or a vulnerable vessel, a vein, you're not going to want to put pressure in those. I got some heart tests coming up and circulatory tests. And one of the things they do is a ultrasound of my carotids and stuff in through here. They want to make sure that they're not clogging up. Maybe they are. I don't know. Have I been a little bit more stupid lately?
Don't answer it.
Is there enough blood going to my brain?
Is the camera
Yeah. This in here, this is the very base of your skull. These are the suboccipitals. Now they're really buried down in there. There's from the C7 to the top of the occipital base right in through here, the top of the occipital bone. There's that much space that's filled in with muscles. There's a connective tissue sail that runs through there. So when we get to some of these structures, it's almost like we're pretending we're on them. So we got to press through stuff that will then translate through, which will translate through, and hope that we're getting to the area. One of the things we take a look at then with this is, can we recreate the symptom that a person's got? That's the guiding thing right there. So there are a few little things that you can look at that to differentiate between the psoas and the quadratus lumborum. If a person has a psoas issue, you can usually slide your hand under through here. If they have a quadratus issue, it hurts more on one side than the other when they try to turn over. So those are two quick screens that you can use. Psoas is almost always going to be bilateral on both sides. It comes right up into the diaphragm. But it comes down and attaches here on the lesser trochanter. So there is a place where we can get at it to put a sensory stimulus into the psoas just below the iliac crest and as it translates into the femur here. This is the safest way to do it. If somebody's pregnant, you can work it here. If somebody has the bigger, harder belly, you can work at it here. If somebody has symptoms of a hernia, or they're very ticklish or whatever, you can work at it here. So keep that in mind when you're looking at stuff. So here, don't you love it? If I'm trying to get to their quadratus, I'll show you a picture. I got all this to go through. If I'm trying to get to their psoas, I got all of this to go through. So if I take this off, then you can see the guts. And this is here, this is a combination of all of the obliques and the fascia, the abdominal structures that come through there. I got to get this out of here before you can start to see right where the psoas is at. The quadratus is over in here. It's an anterior muscle. It's on the front part of the vertebral column, but it's behind everything else. So if I'm going to try to apply pressure in through here, I got to somehow translate all that other stuff over. Diaphragm is up here, and you'll see me use breathing to, because we have inhibitory pressure plus movement, right? So maybe I can get some pressure in through here, but I might have the person breathe, deep breathing. That's how I might get the movement part into it. The quadratus lumborum is over on the side here, where everything from the back and everything from the front meets in a seam called the lateral raphe. And I don't think we actually get too much into quadratus in through here. I think mostly we're squishing that raphe, and because everything is attached to that seam, when I pull on it or push on it, it pulls on anything that's attached into it. So, and then up here, this is where the scalenes are at, and the upper trapezius, and then over in here is where we have the subscapularis on the anterior part of the scapula. The ribs are over top of it here. So, I mean, how am I going to get to that with the direct pressure? And it's in through the axilla. So it's in through the armpit, which is not pleasant. Most of these deeper structures that we're trying to get to, they're problematic, not just because they're hard to get to, but because, and there's structures all around them, because there's all kinds of nerves and vessels under there too. It's because they're not comfortable, they're painful. And so we want to use the broadest base of a compression, because that's what these are not movement, they're static compressions. And then the movement comes from the person moving it or you moving an adjacent limb. Okay? All right. Logan, if I'm centered up, I'm going to use your belly.
Oh, jeez.
All right, so you already know the method, right? You already have that. We're just trying to apply it to these specific structures. So now we need to make sense on it. What's positioning? Where are you going?
Oh, if you're going to squeeze it, better squeeze something out first.
I hope that's unfair. Did you get that?
So other symptoms that people might have with psoas is when they are sitting or when they're going to try to stand up, not at the beginning of the movement, but about halfway through where that psoas starts to engage for stability, because its job is to bring us forward like that or to bring the leg up. Those are the two things it does. So when a person is seated, what they will tend to do is come forward and put their hands on their knees come up like that.
Mm-hmm.
Do you do that?
I think I do.
You too?
I think so.
I know.
All right, so
Yeah.
take your coat off.
Everyone should all do it.
I know. We should
We
all
should all
see
do
how
it.
we get
Well,
up.
go-
Yeah, we should all
Sit.
see who. Okay.
Sit, go.
Now I'm gonna think about it.
I
Now I'm gonna
know.
be like,
I know.
Close your eyes and stand.
All right, now you're just gonna stand up.
Yep.
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 All right, now,
that's
so
what I
that's
do.
one screen. Come on ahead. All right,
Oh, I know. You
Don't
just
think
think
about
about
Just
it.
close
Yeah.
your eyes and stand
all right.
up. Because if you
Yeah,
Okay.
yeah. It's pretty automatic. And so that's screen number one, and I usually will catch that before they even get on the table, just watching.
How does a normal person get up then? Like, what is a normal person
Try.
supposed to,
They,
don't know
you,
how
you
it
should
looks
be able to just get up and down.
without like using your arms as support and all that? I could.
Oh, popped it. Ow. But I did it.
This is one of the things that you want to practice. The people who are older want to practice is the ability to get up and down. So you want to be able to do this.
Yeah, I can. I just think
I
it's
know.
just an
I just
automatic
think it's an automatic.
kind
Yeah.
of thing. Yeah.
So other things that you're going to find is a increased lordosis, because the way the psoas is pulling, you're going to get anteriorly.
If someone tends to walk forward, like they walk
Like me.
yeah,
this.
like me.
Yeah.
I know.
The psoas is going
Could
to
it
be shortened, but I don't know that it's a primary. A
That-
lot of
that-
times
okay.
that's an inner ear
Oh.
issue, and they'll have a short excursion. All right.
Now you said when you sit, that's more of like in the middle of standing or sitting.
Yeah.
What about like right at the beginning? Like when
Sometimes
it comes
people are
back?
just they just feel like they need some stability. So
Because my adopted grandma, like she has a really hard time like
visible though.
getting up. Like she has to like have somebody pull her up, or
Right.
she's got to really get going to get up.
Do you have any
What's
kind of
going on?
back or knee problems?
Well, so
Means
when
probably.
I just stand,
That's why I was
I like
asking.
lean forward.
Yeah.
I
Yeah.
don't
Like
actually like
you're-
pull
you're
down.
hyperextending at your knees.
Yes, that's
no, I'm like that. too.
Yeah,
I'm not
so-
hyperextended, but I can just feel like
All right, so we're gonna put Logan on the table
I feel like
for his anatomy. All right, lay on your back.
You get it all out.
Okay, now come on closer so you can see. Try to stay out of the camera. So I get them on their back, and one of the first things I try to do is see if I can get my hand under here. And I can't. I have to push it. So can you arch your back up a little bit? This is what it would be like. Okay? So as soon as I see that, I go, maybe there's some psoas shortening in through there. The other thing I look at is to see if they've got a rotated leg laterally, externally. Remember how the psoas comes in, buried in all this stuff, but it reaches that greater trochanter. Reaches down here with that greater trochanter, and if it is short, it's gonna externally rotate that leg. So that would give me an idea of what's going on. There are other more specific tests that you can use with it than both knees. You can make sure they're even. You can hold right here. Start to sit up, Logan. All right, the one you feel, that's where the psoas is short. Put your hands right here like that. Get up here just a little bit. Okay, start to sit up a little bit. Did you feel that one come up? So that confirms this external rotation kind of a thing. With these structures that are bilateral like this and coming out of the trunk, you want to always make sure you work on both sides. And you work on the least affected side first. So the most affected side, based on what we just saw, and he hasn't got it really bad because he's not got the lordosis going, is on the right, correct? Is that the right? All right, so I'm going to first focus over here then. So that's a general principle. Work on the least affected side first. Now, I got to get through all of this nonsense, right? Stay focused. I got to displace all of this so I can get down to what's underneath there. So one of the ways to do that is to soften the abdominal wall by having them bend their knees. And then I tend to have them lift their butt up, tuck, and pull it down. Now, this is as loose as it's gonna get. So if I'm gonna work at it from here, then what I want to do is find the location. So you want to come around this way on this side of me. Here's the top of his iliac crest. The camera can't see this. Here's the top of the iliac crest. Here's his ribs. Start to do a sit-up, Logan. Do you see that ridge right through here? That's where the rectus abdominis comes down. So I want to be about halfway between the rib and the top of the iliac crest. And I want to be lateral, so here, and I want to be lateral of that rectus sheath, right there. All right, that's where I'm going to start. I want fairly flat hands. This is going to be softer in here. So you see where I'm at? Here. Go ahead and take any picture you want. And I'm going to start by pretending that I can scooch that whole abdominal, not that much, but that I can scooch that whole abdominal bag over. And then I'm going to come down, flat hand. You can use a fist, flat hand, and when I think I'm there, because you'll bottom out. Remember when we did the abdominal stuff? It's just above that pressure when we did the belly. Remember we massaged bellies? Yeah, okay. We did do that, right? Mm-hmm. Poop scooped, okay. All right, so I'm about where I think it is. I can just lean this arm over. Remember, this is a flexor, a hip flexor. I can say, start to push against me right there. And if I can feel it push up against me, then I know I'm on it. So get your fingers in there. Pretend you know what you're doing. You're going down and towards the spine. So go down first. And then right there. Now bend your knee up a little bit. Can you feel something punch at you? Yeah. All right. Next. Okay, so you need to go down, and then you're going to angle in towards the spine just a little. Push up. Did you feel it?
Yep.
Yeah, it's not mysterious. Okay, Chris. Okay, flat, flat. Okay, down, and then just in a little bit. Push up. Okay. Next. So get right there, and then down, and then, okay, you're on it. Push up. Feel it? Okay. I do this.
Okay.
So down, a little bit in, push up.
Oh, yeah.
Feel it?
Want us to even you out? Want us to palpate this side now?
Right?
Okay, so you wanna start closer to the iliac crest. Flat hand, in, and then a little, there you go, there you go. Push up. Feel it punch up at you? Aren't you glad this isn't a class of 12?
Yeah.
And after lunch.
Right.
And after lunch, yeah.
Down, just a teeny, there, perfect. Push up. Yeah. Okay, can you visualize it? Oh, my nose, my nose, my nose. Can you visualize it in there? See why I'm going, it's here, see why I'm going. There's your iliac crest, your rib, here. Oh, thank you, Logan. Here's my iliac crest, here's my last rib. I'm gonna start there and go in. Start here, get my depth, and then, because it's up against the spine. So in, not like this.
Right.
In, and then just a little nudge towards the spine. Have them activate the leg until you get familiar with it, and then you can feel it.
How long would you like to hold that compression for? Just normal?
I don't
amount,
like
or-
holding a compression. I don't care where it's at. Oops. Can't breathe. He can't breathe! I don't like to hold a compression longer than 15, 20 seconds. I'd rather come back and do it again. Okay, so now we know where it's at.
Now, this might be a blonde question, but like, is it a lot harder to palpate on like somebody that's fatter?
Yep. Because there's just more to go through. Or if somebody has got now if that fat is like most of mine, which is on the outside, you can shake it, you can kind of transplant that over. But if it's on the inside, embedded in the omentum in there, that's harder to do. That's when you switch to the other approach.
What about like with athletes that are super muscular around that area?
That's not the problem.
Okay.
It's the density of the fat.
Because I feel like someone who's skinny but not muscular.
Well, that you
might
will.
be
You have
easier.
to, because
But the
they're
muscle,
not
like,
giving you
might-
any bounce
Right.
back.
She's using
It's
me
like a
as an example.
trampoline. Huh?
That's why she's using me as an example.
Yes, because you're so together.
Yeah.
All right. Now,
Right word.
the function of the psoas is to flex the hip or bend the trunk. So I had him flex the hip in order for me to know I was on the right side. If I have him look towards his belly button, go ahead, that's stimulating all of the structures that would have him flex forward. Following that? If I have him look back, that is activating the antagonist group, all of the extensors. That is how I prefer to do the inhibitory movement part. Okay, so we're gonna go in. I'm not gonna really do it because he doesn't really need it. Okay, if I was gonna work real direct, I would say straighten this leg out, bend it back up. But most of the time, I would say, okay, look at your belly button, tip your chin to your chest, and then tip your chin to the ceiling. Tip your chin to your chest, activates it to the back, turns it off, turns it on, turns it off. Now, I don't always remember that, and so here's how I really do it. Okay, roll your head in a great big circle. Turn it on, turn it off, turn it on, turn it off, turn it on, turn it off. There we go. Usually you'll feel it collapse a little bit. All right, I'm going to do it in real time over here on the side that is actually affected. So leg out. See, we've already got some reflex going. I'm going to take this out because it exaggerates that. I always am messy. Okay, we have the external rotation here. I'm going to show you how to do the release at the leg. All right, so just scooch over next to the table a little bit, Logan, the side of the table. This one's, there's no alwayses, but this is always pretty much a safe way to get to this thing. So I've got this already positioned in an extension, and I need to find the iliac crest, work it down. Now this is more in the groin area. It's one of our no-touch areas, but anytime you're using a straight compression, no glide, no need, you can work over clothing. All right, so that comes across through there and dives this direction to the lesser trochanter. So this position's already turning that leg out for me. If they can't do that, then I would position it like that. This is just harder. All right. All right, start to lift your leg. Start to lift your leg. Okay, there it is. Okay. All right, now make sure that your back is flat. There you go. And push up. And relax. Push up. And relax. Push up. And relax. Now you're also getting quadricep in through here, but by having it externally rotated a little bit, I'm giving myself some advantage with that. Why did I not do this way?
You're close
Yeah,
to the
all right.
no spot.
So, okay, so pick your bottom up, put it down, wiggle, wiggle, wiggle. Did we make a difference?
Does that help with like a groin pull?
Oh, yeah,
Does it?
yeah.
Oh, that's good.
Well, we actually did make a little difference with that. Okay, so that's how you do that one. Bend your knee. Bend
And
your
you
knee.
said that's all the Psoas, right?
Huh?
That's all the Psoas.
That's Psoas. And that's always pretty safe.
How does that help with the groin pull?
Because all that stuff comes in there, and even though you're targeting the psoas, you're on all of the adductors and everything else that's in the area.
Okay.
So, okay, so landmarks, here, on the outside of the rectus sheath right through here, flatten down. Gonna start out, make sure I'm in the right spot, push, okay. Turn your head in big, slow circles. You know what that's all about now. That's turn it on, turn it off, turn it. Go the other direction. Okay. Just give it a break. All
Would
right.
you do both the leg and the
I'm going
upper?
to do the leg now.
But I mean, would you do both, or would you do one?
If they're
or the
pretty
other?
robust, I would do both. If they're pretty fragile, I wouldn't. Okay, slide your heel towards your out flat, and then slide it up towards your butt. Keep your heel on the floor. Good. Again. Makes it long. Bring it up. Makes it short.
Didn't your mom ever teach you not to leave your shoes on in the bed?
There you go. Now,
You glad the camera's on.
There's one more element that you can bring into this, and this is to bring in a frictioning idea. So the knees are up. Same thing, I contact the psoas, make sure I'm there, push, okay. Now, I'm gonna have him turn his legs like that, and turn his legs like that. Go ahead. And I hold my hands still. Oh, nice. Yeah, I feel it like I have to push harder to find it. That's how I feel. So can you visualize what's happening here? The ones I did with him turning his head and his leg are working on the longitudinal part of it. When I have him move his leg back and forth, I'm going back and forth this way. So remember, we've taught you with the grain across the grain, with the grain across the grain. That's all there is to it. So the cautions have to do with how do I get into the area without bruising, without causing unusual discomfort. How do I get it to activate? Because there are vessels that run adjacent in through here. So you need to be kind of aware. If you feel a pulse or anything, you need to move lateral on it. Okay, Quadratus lumborum. So I'm going to have him roll over on his side. Roll over on your side. Did that bother you at all? Okay. Roll over again. Just continue to roll. And then roll up on your other side. No, that did not recreate the pain. Okay. I still have my landmarks of the low rib and the, how's that looking? Okay. And the iliac crest. I want to try, that's narrow. I want to make sure that you're not bumping against that lower rib. So I'm going to have the leg down. That would be the biggest opening right there. This is okay, but you see how when I did that, that opened that up? The other thing it did, however, is make this more taut. So it's like I have to go through stiffer material.
What if you put a pillow under them?
That could help too, under here. And then I bring the arm up, that brings the ribs up. But that also is making that a little stiffer for me. All of the abdominals, all the obliques, the transverse, the intercostals weave into this, that all comes together into a seam right here. The erector spinae group, the latissimus comes across through here, the lumbar dorsal fascia, all of that comes over and seams together right there. My task, my approach is, if I can bend at the seam, if I can bend it at the seam, it's going to put a sensation into it, pretty much all of that. And if I can recreate their back symptom, that's what I'm really after. Whether I'm on the Quadratus lumborum or not, doesn't really matter. So, my position would be, scooch over here a little bit. Okay, I want him up pretty straight. Want that leg out pretty straight. All right, not too anterior, not too posterior, although you will see some people going after Quadratus here. Anatomically, I can't picture that. But that is where the multifidi, the erector spinae, they get bigger in through there. So I'm just going to pretend that I'm getting to the quadratus. I pretend a lot. All right, I want my pressure to go against the iliac crest because I don't want to push against the rib. Whenever we have you use your forearm, we want you to use here so that, you know, I'm coming straight down on it. If I get here and try to use my elbow here, do you see what's happening? All right, so I'm going to hold them right here so they're stable. All right, now the movement is going to be the hip hiking type movement. So I'm going to have him lift that leg is what I will do. Okay, so once I get him set up, I'm just going to cut him in half. All right, you ready? Now this is one of the ones where you will want to bring your table down, or you'll want to use a stool, because I'm going pretty much straight down. So I get into my spot, bounce against the iliac crest, stabilizing, get down as far as I can. This is one of the few times I'll use this hand to stabilize this arm because I don't want to come up like that. And then I'll say, lift that top leg up. Yeah, good. All right, and then I will say, okay, does that recreate your pain? Is that your sensation? Is it?
Yeah, we would.
Is it?
Mhm.
Have you been having some low backish type stuff? This is on the same side of the psoas too. So, okay, so we've confirmed it. We've done the assessment. So now I'm going to apply the pressure down to where I bottom up. Now lift your leg up and down. People want to make a big deal out of it because they want to charge you $500,000 to take a 2-day class to learn to do that.
So what happens if somebody, because I had somebody I was working on and he complained about like the sciatic, whatever.
That's down here.
Right, but when I was doing that, it didn't hurt him, but he said he had a sensation down there.
Okay, this is also where your lumbar plexus comes out through the spinal cord and comes down through and through here. So if you're pressing on some of those nerves that come out through there, and this will, if somebody's complaining of nervy type sensation in this part of their body, or that goes down the side of their leg, they'll call it, anything that's coming out of the butt, they'll call it sciatica, right? It could be that it's really more of that, whatever is, it's seam after seam after seam.
I did elongate him a little bit.
Yeah.
I adjusted him a little bit, and then he said the sensation kind of
Yeah,
went away.
so you're
he was a little too crunched.
if it mimics a sensation that they are experiencing, then you'll work with it. If it's a brand new sensation that they haven't felt before, move.
Okay.
Move.
Even if it feels a pleasant sensation? If it's a new pleasant sensation?
If you were going to make the decision to do that, it would be because you're going to do a little counter irritation.
Yeah.
Just remember, nerves don't like to be pressed on. Yeah, so. Now, a lot of times, the sensation problems that people have back here are coming from the lumbar dorsal fascia. And I am bending that when I come in right here because of this raphe, this seam. But I would be more apt to use cups then in through here because that will lift that. And then if I did that, these together, let's say I had cups right on here, then I'd have them do a hula hoop, hula hoop, hula hoop. All right, do you see how that is pulling that? Do you see how that's pulling that fascia in through there, and then other way?
Work it, work it, work it, work it.
Yeah. Okay.
Yeah.
All right. Now we can extrapolate that same idea inside lying with the scalenes and the suboccipital. Broad base needs to recreate the symptom. So if we give him a little pillow. There he is. So let's say he's got some brachial plexus stuff and he's feeling it down in his elbow, and because we talked about elbow today, he's got that nasty spot behind his scapula. The scalenes are not directly attached to the head. They're all off of the vertebrae into the ribs. So my pressure, see how this is the valley right here? This starts to go back up a hill. So I want to be right in the valley. I always want the nose pointed down so that I'm protecting everything in the anterior part of the neck. Logan, can you take your shirt off? It's in my way. Okay. There's hill, valley, hill. Same thing here. I put my pressure in the valley, straight down. So when you're trying to do you've got pressure angles that go this way, which was kind of what we were doing with the Psoas, and we got stuff that goes straight down. Straight down pressure is almost always in the valley. Okay, so I'm going to come in. His nose is pointed forward. I'm going to apply pressure into the valley. And then I'm going to have him tip his head just a little bit and turn it down a little bit and turn it back. Each of those little positions is going to access one of the pieces of the scalene, because there's 3 pieces on that. I'm looking to recreate a symptom. So it will create a symptom even if they don't have a problem. So don't continue to do this. If they're getting the pain down the back of their shoulder blade or into their shoulder or whatever, and they don't have that as a symptom, stop, because you don't want to create a problem. But I will do that on Logan. All right, here we go. We're going to come straight down and take a deep breath. Okay, that's because they're big breathing muscles, so I know I'm in the right spot. Because upper trapezius should not be a breathing muscle. I should not feel that. I should feel it in the neck, not in the whole back right here. Get lined up. Okay, tell me when you feel something a little nervy. Where does it go? Behind the shoulder blade. Is that your symptom? No. So stop. Stop. Okay. Now I want you to tip your head forward a little bit, and I'm going to apply that pressure again. All right. Tell me when you feel something a little nervy. Where does that go? Top of the shoulder. There. Okay. We're going to tip back just a little bit. Stay behind the sternocleidomastoid. And where does that go?
Kind of stays.
Yeah, okay. And then if I drop my arm down just a little bit, and where does that go? No place?
Kind of a little bit here, maybe starting to go up.
Starting to go up. So I'm chasing a symptom. If I find a symptom, which one of these, if you had one, which one do you think it would be? It goes down your back or here to the shoulder?
Oh, you should just.
Stiff, okay. Okay, so I'm gonna come straight down. I'm gonna get the symptom. Got it? Tell me when I got it. Okay, that more into the top. Right there.
It's about the same.
How about that?
Oh,
Okay, all right. So, it's the breathing muscles. Take a deep breath. Slide your arm. Take a deep breath. That's it. All right, now the suboccipitals, if they're gonna have an issue, they're gonna radiate stuff up. This is a common tension headache type of a sensation. So I want my valley again because I want to cut his head off. All right, and just like down here, I pushed against the iliac crest. Here, I want to push up against the occipital base. Nose is always down so that you're working in the posterior part of the neck. Now, sternocleidomastoid comes right up here too. So, all right, same thing.
The muscle you just worked on was which one?
Scalenes.
Okay, let's check.
Now we're going to do suboccipital and sternocleidomastoid. Okay, so same thing, down. Do you feel anything going up into your head or into your ear? That's good. Tip forward just a little bit. Cut his head off. Anything? Into the jaw. Okay. I'm going to tip back a little bit. Always up against the skull. Straight down. I'm using my bone.
So you'd only tip back because he was feeling it in the jaw?
I quit because I was showing you something else. Yeah. In order to get this part of your arm, your thumb's up. Okay. This is one of the few times I will use my hand to keep this from bending. Got him tucked right in. Feel that. I'm back just a little. And you feel that?
Starting to get a little bit.
Okay, starting to go into the headache and through here. So I want to recreate the symptoms. So if he comes in and he says, I got something here and something here, I'm going to think there's something in that area, because it could be sternocleidomastoid, it could be the splenius capitis cervicis that runs up through there, and maybe I'm even pressing deep enough, the pressure's translating deep enough that I'm into a suboccipital. Okay. Okay, in we go. My pressure is coming. This one I want to table up. This was the matter. Besides, I'm babying that knee. Okay. Now, I can have him roll his head in a circle. Put your head in a circle. Go the other way. Or I can have him roll his eyes. The eyes, rolling the eyes work really good for this, especially with the suboccipitus. Okay, roll your eyes in a big circle. Again, you're only working if there's symptom. Better to come at it a couple, 3 times than staying on it too much at the same time. And you want to recreate the symptom, but you don't want to increase the symptom. Got it? And then you have them put the movement in there, and then there you go. Ta-da! The only one that's left that's a little hard, and we'll get it after lunch, is subscapularis and pecmeyer. And then we'll practice. Cool? Got it. All right.